Okay, so doctors, today we are just going for a different kind of skin disorders or skin manifestations that are not actually discussed almost completely anywhere. But today it's mostly vasculitis and some other diseases we're going to study. So first, cutaneous manifestations of the vasculitis. Vasculitis is basically a vascular disease, but why it's important because this is the most common condition that is coming in front of you while you're seeing a patient in a GP clinic. It's important that you need to know if the patient is suffering from a very chronic or condition or maybe some autoimmune conditions that needs an urgent referral, or it can be managed at the primary care, or is it just a reassurance or just a supportive care is needed. So that's why vasculitis is one of the important things. Basically, it's inflammation and the necrosis of the blood vessels. It can be localized or systemic depending on the kind of diseases. So it is divided into three kind of classification. Number one is a small vessel. That is the most common coming in the primary care. So in that small vessel cutaneous, a small vessel vasculitis, HSP, inoculum that you all are aware of, exercise-induced septic, some urticarial, and there are some cryoglobulinemia and ANCA-associated. So medium-sized vessel is PAN, Kawasaki, and nodular basically, and large vessel disease, it's as everybody knows, giant cell arthritis and Takayasu arthritis. And there are some other conditions that has extra intestinal manifestation like IBD and some extra respiratory like sarcoidosis, and some hematological malignancies are also associated with vasculitis. In these pictures, as you can see, these are all kind of like first picture is a small cell, okay, a small vessels. Second one is the nodular vasculitis. Third one is very common that you can see inoculum purpura. And the last one is exercise induced. We will be discussing bit by bit on every topic. So firstly, how the patient is coming with the vascular disease or vasculitis. Basically, there will be some kind of palpable purpura, and there are some other manifestations we can see. But in this condition, mostly why the purpura is present is the erythrocyte extravasation from the vessels, and it is apparent onto the skin. So most common that are identifiable is the small vessel vasculitis, and it is mostly on the dependent parts, and it will always come as papules and plaques and a little bit of bulla sometimes. Why this condition is important, as it can also cause a post-inflammatory hyperpigmentation disorder that can be concerning for the patient. And there is a form like net-like pattern of the purpura that is also known as gratiform, and it is basically medium to large vessel vasculitis. Differentials can be many other things like easy bruising, could be hematological, could be infection like cellulitis. It could be any blood disorder like thrombocytopenia and scurvy, especially vitamin C deficiency. So it's important to know what kind of manifestation is it. So medium vessel involves always there are small vessel could be localized, could be systemic, but as you go on from the size of the vessels like medium to the large, then definitely it will have the systemic features. The other features could be ulceration nodules and libido pattern. Ulceration, necrosis, and nodules, as everyone is aware of, it could be in a small vessel, superficial ulcer, but it can be deep in the larger vessels. Other differentials, as I told, like could be cellulitis, it could be even embolize and could be associated with with some drugs and malignancies. The important thing over here is like PAN, polyarthritis nodosa. It also the nodules will go along the vessel direction. So this is one of the picking point, and also that nodular vasculitis is basically present on the lower third of the leg or the ankle. So mostly on the dependent part, you are going to see the nodular vasculitis. Levadoreticularis is one of the common pattern in the vasculitis. It is just a kind of reticular pattern, basically, and mostly on the extremities. It can be physiological, it can be pathological, but physiological is mostly like in young women, and you can see it getting disappear as you are rewarming the skin of the patient. And it can be pathological also, like in some diseases, antiphospholipid syndrome and PAN and some other ANCA, etc. associated. Few of the findings are very particular to some diseases like splinter hemorrhages. It's a manifestation specifically present in the infective endocarditis. And if it could be like digital ischemia, then it's definitely a larger vessel or could be cryoglobin. If the patient having the nail fold changes, then it is not just a skin or vessel disease, it is a connective tissue disorder. As you can see in the picture, the first one is the ulceration. Second one, you can see it's a nodules, present nodularity. And the third one is reticular pattern or livedo reticularis. So sometimes it's asked in the AKT that what kind of pattern or what is it actually? So it is levato reticularis, the third picture. So the most common in cutaneous is small vessel vasculitis is in the vasculitis will be CSVV cutaneously. So it is basically exclusion criteria. You are going to exclude all other diseases like it could be some malignancy, some autoimmune, SLE, etc. And if everything is perfectly fine, and also livedo reticularis and systemic involvement is not involved in the patient, then definitely it's cutaneous small vessel vasculitis, which is a very reassuring condition. It will self-limit from weeks to months, but yes, it can also flare up over years. So how it is mostly seen like this in the patient. So it is a cutaneous um, small cell vasculitis. Okay. Every time you're going to see a cutaneous a small vessel vasculitis, just know there could be palpable purpura on the lower limbs, especially there could be systemic features and some raised inflammatory markers like ANA and some complement changes. So you can just do the skin biopsy by referring the patient, and also its management is quite fine. Like we need to just treat the underlying cause. It could be some rheumatological or some, if it's needed, so a systemic steroids can be given to the patient. Very common condition, nodular purpura, everyone is aware of it, is IgA immune complex deposition. So it's also a small vessel vasculitis, one of the very common. How the patient is presenting is just not the skin. In fact, it will include the GI system, your renals, your joints. So the triad or tetrad, you can say, skin, GI, and renal is definitely involved, but joints might be or might not be involved. So patient might be coming with the skin, some GI problems, could be hematuria, and some joint problems. It's basically in children. If the patient child is presenting with the palpable purpura on buttocks and legs and having joint pains or any colicky abdominal pain or possibly hematuria. But this, even though it's in children, it's just kind of reassurance because all you need to do is the supportive care. Just give analgesia, adequate hydration, monitor the blood pressure, and also keep on checking the urinalysis of the patient. Steroids could be given in the severe abdominal cases or if the renal and the GI involvement, but that's not our domain. We are going to refer the patient. This is inoxial and purpura, mostly on the backside of the legs and the buttocks of the child. Then comes exercise-induced or septic vasculitis. So exercise-induced is mostly when they are older adults and they are pruritic or burning petechial rash. Okay, so it could be on the legs and it is mostly after prolonged walking or exercise. But if you run up the systemic workup of the patient, is mostly the normal. All we can do is not refer the patient for if it is a hematological condition or any blood disorder. No, all you can do is just rest for the patient, some leg elevation and compressive stockings. Tell the patient for having the cool packs and avoid triggers like long standing or going for a long walk, and just reassure because it's very benign condition. The patient feels otherwise well. If the pain is associated, you can also provide NSAIDs. In septic vasculitis, as the name suggests, its immune complex will be negative. In most of the vasculitis, there could be immune complex positive, but when there is septic vasculitis, then definitely it's not immune complex. So it can be infective endocarditis, gonococci, meningococci, or some other infective organisms. Features will always be like petechia, ecchymosis, mostly purpura, and hemorrhagic bulla could be there also. What do we have a sign of infective endocarditis? Number one is splinter hemorrhages, oscular nodes that are very painful and mostly on the finger and toe of the patient. The other one is Janeway lesions. So Ostlers is painful, but Janeway is non-tender, or you can say it's on the palms and soles. So there are two things, Ostlers that can be on the finger and toes, and Janeway that's mostly palm and soles. This is exercise induced. One another classification is cryoglobulinemic vasculitis, as its name suggests, that is basically palpable purpura with some um, body aches or joint pains, also having peripheral neuropathy or some renal disease in patient with having cryoglobulins. And it is mostly associated with hepatitis C virus or any autoimmune disease. So we need to rule out if the patient is suffering from any other disease because it can involve in the management plan, like it can affect the management plan. It is also a small vessel vasculitis and mostly in it is precipitate in the cold, and as soon as you rewarm the patient, it is going to resolve. There are many kinds of like type 1, type 2, 3 present. So let's not go in detail in this. What we know is the intermittent symptoms of the patient. Mostly it is worsening on cold and prolonged standing. When you check the complement level, it is low C4, like 90%, and RF will be positive, like in type 2 and type 3. Important is you are going to start the systemic steroids, but it can worsen underlying infection long term. Okay, so for that, we need a specialist referral. Cryoglobulins, it is always tested in the secondary care. Then comes the Waldenstrom purpura or urticaria vasculitis. Okay, one important thing in cryoglobulinemic vasculitis is that we are going to treat the underlying cause, could be HCV or any other HCV. Basically, we are going to start antiviral or some immunosuppression like steroids plus minus rituximab, and also the referral to the nephrology and the dermatology. These two names might be some kind of new in front of you, but it's kind of skin disorders, rare, but it is happening in the female predominantly, mostly on the lower limbs or the dorsal of the feet. And it stays for like 1 week. How it is triggered by prolonged walking, standing, and sitting. patient will complain of itching and burning sensation. And when you go for the investigation, mostly IgG, ESR, anemia, and leukopenia will be there. Again, the antibodies might be positive in these cases like ANA or anti-OSCE. And also, if it is in any condition of the skin, lower limb or on the dorsal of the female, then just ask regarding Sjogren's, SLE, and rheumatoid. Then comes the urticarial vasculitis. We know about the urticaria, but vasculitis, if it is coming with the urticaria, it's kind of different. Firstly, patient will be having burning, then itching. Okay. Burning is another feature of our one of the very common skin condition. If you can drop in the chat box, that is also positive for burning. And in this condition, urticarial vasculitis also having the burning, then itching. Urticarial lesion, it will persist for like more than 24 hours. It just doesn't go away. Like in urticaria, sometimes there is acute or chronic flare-ups. So in acute urticarial vasculitis, the patient will be having this lesion for at least 24 hours. Again, patient is not just having the skin condition, it will also include angioedema and further off non-complement and hypocomplement type. Okay, so on the first picture, if you can see, what could be the first picture? Anyone who wants to say it's the first, all obviously Walden syndrome, and the other one is the urticarial vasculitis. You can see the wheel-like rash, but again, it's in the vasculitis measure. Then comes ANCA-associated vasculitis, um, Wagner granulomatous, and the microscopic polyangiitis, one of the very important skin condition, the vasculitis. So firstly, there are triad of like small to medium-sized vessels. There could be necrotizing granulomatosis and also glomerulonephritis. This skin condition is very uncommon, but again, it's with the palpable purpura and on the extremities, but with the oral ulcers present over here. In this condition, as it is vaginal pneumatosis, respiratory will be like involved, and also some kind of renal involvement will be there. So always in all kind of small or medium size vasculitis, we need to rule out regarding any respiratory or renal decompensation. Again, the autoantibodies will be positive for ANCA. C ANCA pattern is there. Microscopic polyangiitis is systemically, mostly small capillaries, and again, it could be onto the skin, and systemic will have a fever, weight loss, and myalgia. Again, for this P and is positive. So both of them, the antibodies are different. For Wagner's, this is Priyanka. For microscopic, it is Priyanka. Again, this first picture is of Wagner's, and the other one is of microscopic polyangiitis. You can see in Wagner's, the most of the purpura are combining to form a bigger wheel, but in the microscopic polyangiitis, mostly the purpuras are away from each other. Then Sjogren's or the eosinophilic granulomatosis will be there. One of the important in this condition is patient might have asthma, some blood eosinophilia, and necrotizing vasculitis will be there. There are several stages, one, two, three, and importantly, what is important in this condition is skin is 70% involved, but the autoantibodies will be P ANCA and C ANCA, rarely a diagnosis in this case. Okay, MPO P-ANCA can be diagnosed, but C-ANCA is rare. Okay, so again, this microscopic polyangiitis and Wagner treatment is almost similar. Both need high dose steroids, and rituximab is or cyclophosphamide can be given for any induction. And all of these vasculitis will involve systemic steroids as whole. This is short straw. Okay, so now comes the pan or polyangiitis nodosa. As its name suggests, it's a necrotizing kind of inflammation of the medium and small arteries. There is no involvement of any renal or no involvement of arterioles or capillaries or venules. This is basically just small arteries. What happens mostly where the vessel is bifurcating or dividing, there will be having the pan or polyarteritis nodosa. It can grow into the microaneurysm, some thrombosis, or some ischemic infarction. The most important cause in this condition is hepatitis B. Like in cryoglobin, we are suspecting HCV as an underlying cause, but in PAN, it will be hepatitis B. And systemic features again, weight loss, some hypertension or renal effect, and ischemic heart disease could be there, GI involvement, and most specifically, it will involve almost every major organ of our body. Peripheral neuropathy can be there. One important thing that we read earlier, most of the times in the small cell vasculitis, lung is also affected, but PAN is the only thing in which there is no renal or lung involvement. Okay, mostly heart and GI is involved. So here again, subcutaneous nodules will be there again on the lower limb or near the vessels because it will follow the vascular vessel um, according to the nodules. Livedo reticularis or reticular pattern will be there, and there could be ulceration that is punched out appearance like this. Okay. Next disease is Kawasaki. Basically, it's the kind of acute condition in the young children. Everybody knows it's kind of medial cell vasculitis, and it's that diagnostic is mostly if the patient is having more than 5 days of fever and along with any rash, any eye problem like conjunctival injection, oral changes, cervical lymphadenopathy, or the peripheral changes, then definitely this condition is known as Kawasaki disease. Its main complication is coronary artery aneurysm. So we have to be very particular in this disease. Okay. Mm. The treatment again in this condition will be high dose aspirin and IVIG. Mostly it will reduce the aneurysm risk of the patient. It is mostly in the children who will be presenting like this and on the hands. Okay. Now comes the nodular vasculitis or large vessel vasculitis. Nodules, again, if it is on the lower third or on the leg and the ankle, then it is definitely affecting the medium size of vessels. As more of the vessel is involved, more bad is the condition. Like medial is the nodules, then larger vessels can involve the ulcerations also. Always exclude TB before diagnosing the nodular vasculitis because sometimes the PCRs are also negative, but we still need to rule out because of false negative results. TB-associated nodular will be Bazen's disease, and if it is giant cell arteritis, or you can say temporal arteritis, mostly in the women more than for 50 years, then associated features will be headache, jaw claudication, some visual loss, And ESR and CRP will be definitely raised in this condition. The only diagnostic feature can be investigating by doing the biopsy or PET-CT of the patient. Treatment is urgent high-dose prednisolone because it can cause the loss of vision. So prednisolone up to this 50 to 60 milligram per day will be started for the patient. Um, and direct referral to the ophthalmology or rheumatology department. So another is in the large vessels are is Takayasu arthritis is also common in the young women, mostly in Asian ethnicity. It will come as upper limb claudication, sometimes absent pulses, and patient might be having high blood pressures, and their kind of bruit can be present. All vasculitis investigation, if we come on the same page, it can include some baseline, some immunology, and all other basic investigations. So CBC, urea, electrolytes, LFTs, glucose, CRP, ESR, and clotting are the baselines for every kind of vasculitis. If we go for particulars, so NA, NCA, complement, and RF factors, cryoglobulins for a particular disease according to the appearance, cutaneous manifestation. If the infection screen is seen, so hepatitis B for PAN, hepatitis C for cryoglobin, and HIV, ASO titer, and throat swab can be taken. Urinalysis is a urine dipstick for any protein and to rule out for henoxylin in the children. So if the patient is in front of you and you cannot diagnose the case, so definitely you're going to refer the patient. In some cases, there could be direct immunofluorescence testing or some biopsy can be taken for that. Uh, as we studied, there are many lung disorders, lung involvement, renal involvement. So we will just go for the all baselines like chest X-ray, CT abdomen, pelvis, and chest to rule out if there is any systemic features. Urine, urine protein, and you are going to refer the patient to the second report. As a whole, if we are going to manage vasculitis, so for cutaneous small vessel vasculitis, you are going to first identify and rule out if it is the criteria of exclusion. Otherwise, if it is benign or you just need to reassure the patient, like in some exercise induced in old age, then leg elevation, some NSAID, oral corticosteroids, colchicine or dapsone or can be given. And if the patient is having continuous recurring and relapsing condition, then yes, you're going to refer for any immunosuppression therapy like azathioprine and methotrexate. And if it is complement positive like ANCA, then cyclophosphamide and high-dose steroids play a vital role in that. You're going to start with the induction therapies. Induction is mostly with the cyclophosphamide or high-dose steroids, but the maintenance will be azathioprine. Clinical takeaways in this topic would be vasculitis will be classified as like small, medium, and large. And also palpable purpura on the dependent side is the diagnostic feature of a small vessel disease. Red flags for the OSCE point of view, neuropathy, necrotic digits, or any renal involvement, or any constitutional illness, then you are going to refer the patient for urgent care. HSP is IgA mediated and mostly it is self-limiting. So you just have to do the reassurance and supportive care to the patient because supportive care is important. Why? Because it can also cause some severe renal involvement. So we just don't reassure, we also provide the supportive care in this condition. Cryoglobulinemia is one of the important things to rule out if the patient is having hepatitis C because if it is hepatitis C underlying condition, then high dose steroids might worsen the hep C. So it's important to diagnose also. Again, for giant cell and for microscopic polyangiitis, you are going to run some P and CN. Nodular vasculitis is one of the causes you are going to exclude the TB. Now comes urticaria and some viral example. Okay, urticaria, one of the very important and most frequently asked questions in our MRCGP International. Acute urticaria could be very common in the primary care. Mostly it's hives or wheals on the patient's body, resolves within 1 to 3 hours, but can stay up to 24 hours. It can also be associated with the angioedema because as we studied in the urticarial vasculitis, there was angioedema present also. So in acute urticaria, one of the other signs can be angioedema, like the patient's face will be having swelling or maybe oropharynx, hands, and it can last up to 72 hours. Okay. Sometimes patient is coming with the fear of getting sepsis or some infection in the blood. So we just need to reassure him regarding the urticaria. It's not a lethal condition, but yes, if it's not treated on time, it can cause anaphylaxis. But if not treated, anaphylaxis is basically when the patient is having rash, not only the rash, along with the breathing difficulties and some cardiovascular compromise, then definitely it is anaphylactic shock. Otherwise, just a skin condition, reassure the patient, give the definitive treatment, and just discharge the patient. Sometimes, if the patient is having more than 6 weeks of the same rash, then we can say it classify it as a chronic urticaria. Okay, if it is like more than 6 weeks, very less of them, like 8%, will go up to the beyond 6 weeks. Central edematous wheal with the surrounding flare will be there, and like annular clearing, like in tinea, we will also be having it in the urticaria. And it doesn't have any proper body size. Happen anywhere in the body. So you can see central clearing, and all the wheels are combined together to form a complete patch of the urticaria. So it is acute urticaria. The right side is in the child. Mostly it's not known what causes the acute urticaria, but there could be some drugs and foods and sometimes even exercise associated also. So drugs include penicillin, aspirins, and say ACE inhibitors. That's why it's very important to ask the patient if they got any drug allergy before giving the treatment to the patient. Foods include nuts, some white fish, shellfish, etc. In these cases, why it's important because it can also cause angioedema, and angioedema can further cause respiratory difficulty. And sometimes it's bee and wasp stings, and sometimes it's also when there's food trigger and exercises together in it. ACE inhibitor, ACE inhibitor side effect is angioedema. Okay, from exam point of view, also without even skin condition, if the patient is just developing angioedema, then his blood pressure and hypertensive medication history is very important because if it is not starting as soon as you are starting the medication, it can even develop years after the medication. So ACE inhibitors side effect is angioedema. How do you manage the patient? Is just identify and avoid. So there could be some food diary and some patch test, but it's not basically useful because this kind of type 1 reaction. Second generation antihistamines is given in this case like is fexofenadine 180 milligram. And also the patient can use PRN or regularly these medications if needed. And sometimes if the patient doesn't want any sedating medication, so this one is the best to go for. Okay. Another is famotidine H2 receptor, but antagonist, but it is not very important in this condition, not very effective. And type 1 first generation is often avoided. So what you can give is just a short oral course of prednisolone, like 30 milligram, 40 for 5 days. And if this is the anaphylaxis, like skin is involved, breathing is involved, also angioedema, then you're going to give EpiPens to the patient, tell them and educate them about that, and further you can also refer. Chronic inducible urticaria, it's many types, like symptomatic dermographism. This might be the first time you're hearing this word. It's just kind of shearing force on the body. Sometimes there are people whose skin is very sensitive, where they put their hand or arm, they get the reddish area around that. So that is symptomatic demographism. But there could be other associated like delayed pressure urticaria, some cholinergic urticaria. These are all involved with conditions, with chronic conditions that you cannot just um, treat the patient. It will come and go, come and go. So in this condition, try to tell the patient it's a kind of chronic condition. It might stay with that with you with for the lifetime, but the triggers can be avoided in that case. Like in cold urticaria, just after cold exposure, so try to avoid that. Solar is different, and sometimes even the contact urticaria. Okay, so these are three kinds of urticaria you can see in the picture. Okay, so the first one is the pressure one. Okay, we studied here delayed pressure urticaria. Sometimes patient is working with hands and feet. Because of the continuous pressure, they can develop a condition like this first picture. The second one is cholinergic. Okay, cholinergic urticaria, and this last, the patient back is sensitive, and this is known as symptomatic dermographism. This last picture. How to manage this, avoid the triggers, reassure the patient, and antihistamine can be given the long term. But second generation is more effective and it can be taken up to like more than 4 times a day. And if the patient is really bothered by this condition, then some omalizumab can be given, but it's not under our domain. So we are going to refer the patient according to the impact on his life. Cholinergic, again, it has another medication, montelukast, 10 milligram. You're going to give the patient at the primary care. And sometimes patient is bothered by their symptomatic demographism, like this third picture. So in that condition, phototherapy like UVB and PUVA therapy can be given. Delayed pressure can be given dapsone and sulfasalazine. For cold urticaria, there are EpiPen, cyclosporin, and for solar urticaria, they can refer it because phototherapy for desensitization is the key feature, key treatment in this. Okay, so now comes viral exanthems. Very important and very much common coming in the exams. So mostly in the childhood. The rash, some systemic features. Always rash is having some kind of fever, malaise, and some headaches or some lymphadenopathy in few conditions. Sometimes these viral conditions are very important to diagnose in children because sometimes there are pregnant ladies around them. So to reduce the exposure, it's very important. As the people who are going for OSCE, they know that viral exanthems like rubella and chickenpox has very adverse effects in the pregnancy. So some of them might have to terminate the pregnancy. And so that's why it's very important to diagnose as soon as possible for the child and for any contact. So if there is any rash that is coming firstly on the face, this is definitely measles, rubella, erythema, infectiosum. And this is fifth disease as we all studied. If it's coming on the trunk first, then it's roseola infantum, scarlet fever, unilateral, like this is unilateral laterothoracic example. But most commonly, you are going to study roseola and scarlet. And if it is papulovesicular pattern, chickenpox, everybody knows. And if it is extremities like hand, foot, mouth disease, COVID-19 toes, and PPGSS, we will be studying this. So very importantly, from where the rash is started in the patient describes what kind of condition the patient will be having. So in measles, or in other words, rubiola, this is caused by paramyxovirus, and there it is notifiable condition in some of the regions, and incubation is 7 to 18 days. Patient might start having fever, cough, red eyes. So there is a triad like cough, coryza, and conjunctivitis in the measles, and sometimes photophobia of the child is a kind of in the older children. The rash is erythematous and maculopapular, but it lasts like 4 to 7 days, started from the face, going down to the chest and abdomen, then going arms and legs. So it's kind of peripheral um, distribution to the patient. Hoplic spots is it's on the mucosa of the child uh, against the second molar tooth. Okay, but it can come on the 1 to 2 days before the rash. So mostly the patient will be having a prodrome or like this fever and red eyes and conjunctivitis, which where we can mistake it as a viral condition like flu. But definitely when the rash appears after the 4 days of these all prodrome, then it is measles. And it is an infectious condition, so we have to isolate the patient and some supportive. Since it's viral, we are not going to give any antibiotics in this condition. Complication might include otitis media, pneumonia, diarrhea, convulsions, but it's very important to treat the condition or to give the supportive treatment. It can be seen like this in the dark skin, and here in the lighter skin, it's kind of difficult to diagnose in the darker skin. But again, the pattern of distribution is one of the important thing to ask from mother. Then comes the rubella or the German measles. Basically, it's a rubella virus. Again, these viral condition in some of the countries is notifiable. Incubation is 14 to 21 days. Like even 2 weeks ago, if a pregnant woman met a child with the rubella, then definitely she might have gotten the contact. The prodrome is basically 1 to 5 days, like a patient will be starting having mild fever, again conjunctivitis. Don't mistake it as a virus like flu or cold. How you will get to know it is rubella or just general flu? Post-auricular lymphadenopathy will be positive in this patient. So um, the rash is basically pink or light and mostly in the face and neck, then trunk and then limbs. This pattern is similar like the measles, but measles doesn't have post-auricular lymphadenopathy. Rubella must have post-auricular lymphadenopathy. Again, it is infectious like 1 week before to 4 days after the rash of onset of the rash. And pregnancy risk is like fetal defects are there, and we might have to send the patient for the termination if she got contact in less than 16 weeks of her pregnancy. So very importantly, even the woman is not having any kind of rash, just a contact can also cause her for the cataracts, deafness, cardiac, and mental handicap of the fetus. So in less than 16 weeks, you are going to refer the patient for the termination. But in 16 to 20 weeks, there are minimal risks but still patient might get the deafness or but it is not detected on ultrasound, so we just offer the patient to see a gynecologist. They might go for further serial ultrasounds, but still it's not sure because it is not detected on ultrasound. So there are two things. If the patient is coming before 16 weeks with rubella contact, then you are going to terminate, ask for the termination, advise for termination, and then refer the patient. And if it is after 16 weeks, 16 to 20, then no termination is required, but still the risk of deafness is there. There is no treatment of this condition, just if the immunization is essential, but definitely not during the pregnancy. MMR can be given after the pregnancy. Okay, so this is rubella, mallar flush on the cheeks of the patient. So erythema and infectiosum or the fifth disease or slab cheek disease is again parvovirus B19. Mostly it's spread with the respiratory droplets. So previous two diseases were direct contact like skin to skin, but this condition is respirate from the respiratory droplets. And its incubation period is again around 1 to 2 weeks. 3 weeks is for rubella, or almost 1 to 2 weeks is measles, and 1 to 2 weeks is fifth disease also. The age limit is 4 to 10 years, and mostly in the winter and the spring. Occasionally, always in any viral condition like these will have a prodrome. Again, low fever, headaches, any upper respiratory tract infection, any joint pain or malaise in general. But when the rash it started on the cheeks, so slab cheek appearance will be there, but it will not involve the nasal bridge and the periorbital area, and it will be fading away in 1 to 4 days. Okay, and phase two rash might spread on the trunk and extensor extremities, but it will be on the reticular pattern. So every time you're seeing lacy reticular pattern of any rash on the trunk, it is fifth disease or scab cheek disease. Okay, and it can again last for 5 to 9 days, and yes, it can come back. This disease is infective if the rash is not appearing. Like before the rash appears, the patient will be infected, but as soon as the rash is there, the infection period is gone. The fetal loss can be there, like 9% infection in the first 20 weeks. So there is a risk of hydrops fetalis, and if there is a contact of slab cheek with the pregnancy, pregnant woman. Okay, you can see the patient like this. Mostly extremities involved and rashes. But the first prodrome or first, mm, you can say, is on the face. Then comes the rosula infantum. From its name, it's a kind of rose spots, but infantum. Okay, it will be for on infant. Caused by herpes virus 6 and 7, airborne droplet disorder also, disease also. It is incubation for 1 to 2 weeks, 10 to 15 days, basically up till 3 years of age. Okay, it can affect up till 3 years of age, and having a high fever for at least 3 days, then the rash begins, and abdominal pain, malaise, and sometimes upper respiratory tract infections. Rash is a small pink red macules or papules on the trunk. Okay, then arms and neck, and sometimes on face and legs. So basically, it's mostly on the trunk and arms and legs, and just stays for 1 to 2 days. Um, there could be the infections could be before the fever, but as soon as the fever is there, the patient might be not effective anymore. It is mild and self-limiting, but rare complication can involve encephalitis. This is roseola infantum, maculopapular rash. Scarlet fever. Scarlet fever basically from the Streptococcus pyogenes. It is spreading by coughing, sneezing, and direct contact. Incubation is 1 week, almost 1 to 7 days, and can affect from 2 to 8 years of the uh, age. Prodrome, again, similar prodromes in almost every kind of viral examples is fever, sore throat, headaches, nausea, and vomiting. Rash is basically fine papular, or you can say sandpaper-like appearance. And again, on the chest and stomach, central distribution will be there first, then whole body, and could be peeling of the fingertips or toes or groins as it is going away. So patient might have flushed face, and one important thing with the center or chest involvement of the rash, sandpaper-like rash with strawberry tongue, then it is diagnostic of scarlet fever. Patient might be infectious for 5 to 7 days, and treatment always include antibiotics. From all of these viral examples, this is the first where the oral antibiotics is involved. Otherwise, all the previous work was supportive and hydration and rest and isolation. But this scarlet fever is from the Streptococcus pyogenes, a bacteria, the 10 days of antibiotic just to prevent the complications also. But it can also cause late complications like rheumatic fever, mitral or aortic valve stenosis, and some liver renal bone damage. So this is a strawberry tongue. And when the rash is going to disappear, you can see the peeling of the skin. This is significant in the scarlet fever. Now comes the chickenpox varicella. Everybody knows the reactivation of chickenpox, or it is known as varicella zoster virus. This I was talking about in the start of the session, like varicella zoster also comes as the burning sensation of pain. Okay, so clinically, it's varicella zoster person to person, and also its incubation is 2 to 3 weeks, so 10 to 21 days. Mostly, it's occurring in around 10 years. Okay, most of the kids might have it up till 10 years. Again, the prodrome is including cold-like symptoms, but it includes high temperature instead of low temperatures. Rash will be there, like drops of macules, sometimes raised papules, sometimes it can change into the blister, but what's important in this is very itchy in nature. And it also can cause crusting, but once there is crusting happening, the patient is recovering and there is no more infection. He is no more infectious. Distribution is mainly trunk. It starts from the central, like the scarlet fever, mainly trunk, then on the limbs. It can be anywhere, but mostly starting from the center of the body. It is highly contagious, like 90% of the people who are getting in direct contact at least for 15 minutes, they are going to have the chickenpox. Again, before 1 to 2 days of the rash appearance, and until the lesions are crusted, patient is infected. And the crustation appears like 5 to 6 days. In 5 to 6 days, there will be appearance and crustaceans. Serious groups involves neonates, adults, pregnant women, some immunocompromised, and what it can do is pneumonia and encephalitis and some other secondary infections. In pregnancy, importantly, even for the OSCE point of view, congenital varicella syndrome can occur in first 12 weeks. Okay, and it says in less than 20 weeks, we can offer the immunoglobulin, but only when the patient is not having the rash. But if the 20 weeks and beyond, then definitely oral antiviral treatment will be given. Okay, so as soon as the patient is getting affected from chickenpox, there are less risk of getting infected and having complications. But after 20 weeks, there are more complications can happen. So we are going to start the antiviral treatment. In late pregnancy, there could be risk of premature delivery, and even the patient might have, the neonate might have chickenpox. It's very important to particularly like serious for the mother. If the mother is getting this chicken pox 7 days before the delivery, then yes, it is infection going to the baby definitely. So sometimes we are going to delay the delivery plan for the pregnant woman until she is getting her antivirals. Okay, so delaying the delivery up till the antivirals are given is one of the chosen treatment plan in this condition. Again, if the patient, like neonate, is getting chicken infected with the chicken pox, we still have the treatment plan for child as to give the immunoglobulin and treat with the acyclovir if very severe. You can see there is a starting in the first picture, then it can go on to the blisters and then crustaceans are happening over there. And what's bad about the chicken pox, it can leave the scar marks in the patient. Now comes hand, foot, and mouth disease. Agent is called secuvirus A16, A10, and it is really highly infectious like chickenpox. So school exclusion is very important. Incubation is 3 to 5 days, and again, it's less than 10 years. Many children might have this. It will again start with the low-grade fever, malaise, etc., upper respiratory tract kind of symptoms. Oral lesions are very painful ulcers on the hard palate, and sometimes the child is not able to eat and drink because of the painful ulcers on the palate, tongue, and the buccal mucosa, but it will take a week for them to resolve. And if there are hand and foot lesions, especially it's a macules and papules, but mostly it's on the hands, then on the feet and the side of the fingers, and it also can go encrusting in 5 to 10 days. Okay, and it's rare complication. Again, virus, mostly complication. Either they're going to do meningitis, encephalitis, in some cases pneumonia. So this is hand, foot, and mouth. This is how they are involved. Hand, foot, and mouth disease. COVID-19 cutaneous manifestation. It was apparent after the COVID-19 came. COVID toes, you can say red, tender, well demarcated areas on the toes, and it stays for like 7 days. Okay, treatment uh, just a superficial topical potent steroids, especially dermovate, once a day. It can have desquamation or swelling, and also the management is just keep warm the toes and also avoid cold immersion. Aspirin can be given in some severe cases and dermovate. Okay, it can appear like this. Now, last but not the least, Guanete Crostic syndrome or PPGS, papillary purpuric gloves, and SOX syndrome. So, first is papillary acrodermatitis. Its agent is EBV. Okay, infectious mononucleosis also have the similar um, um, organism, and this one also has the EBV. So prodrome is again fever and respiratory rash will be non-pruritic and red and purple papules. Distribution again starting from the face, then going on to the extensor limb, and trunk is not involved. The only condition where you can see trunk is not involved is Danoti-Crosty syndrome. And this is self-limiting condition. So the last is the papillary purpuric gloves and sock syndrome. As the name suggests, it will be papules and purpura, but on the hands and socks area. Wrist and ankles last 1 to 2 weeks, and mostly it's in the young adults, one of the second parvovirus. Okay, one was the slab cheeked. slapstick that was caused by parvovirus B19. This is the other condition caused by parvovirus B19. And it remained infectious even after the onset of rash. This is not like the fifth disease. In fifth disease, when the rash appears, patient is not infectious, but in this condition, it is also infectious even after the rash appears. So you can see on the face, there's rash over there, and the second picture is of glove and socks. The first picture is Ganaty, okay, from the EBV virus. What we know over here, second generation antihistamines are the mainstay for urticaria, especially if hexaconidine 180 milligram, even 4 times a day. First generation is avoided because it can cause cardiac problems, and there is no role of famotidine, etc., in urticaria. Measles and scarlet fever, these are the notifiable diseases, especially rubella is very important if there is an exposure of rubella and chickenpox and even the erythema infecciosa to the pregnant lady. Chickenpox in pregnancy, if the patient is getting like less than 20 weeks, then we are going to give immunoglobulin to the pregnant lady. But if it is more than 20 weeks, you're going to give antivirals. Antivirals are mostly given 5 times a day, 800 milligrams for 7 days. Erythema infectiosum is not an infectious once rash appears, but in PPGSS is still infections after the rash. And these two are caused by parvovirus. Okay, again, if there is COVID manifestation, so aspirin can be given in dermovate. So this was all for today.
Thank you very much.
Any queries?